So I'm excited to sort of wrap up this last part of the series of conversations we've had about your foundational experience in ECT and the development of TMS, and more broadly in brain stimulation and specifically brain stimulation for mood disorders. So we started talking a lot about the early history of ECT and then your foundational contributions. We went on to sort of to discuss the development of ECT. Again, keep this in the context of some compelling theories you have about, what depression even is. And then we moved on to essentially electrical stimulation without seizures, right? Just TMS and its origin. So I wanted to maybe start today by asking you about some other neuromodulation techniques that have been looked at, including for mood. And so maybe start to talk about with VNS, if you can say maybe, what your perspective is on VNS, where it's come from, where it's going.
Yeah, I first learned about VNS at a international epilepsy meeting in The Hague, where I was giving a keynote talk on the impact of seizures on cognition. Essentially, I was speaking to an epilepsy audience about the effects of seizures and ECT on cognitive parameters. And I attended, just out of interest, a session on vagus nerve stimulation, which was just emerging as a clinical tool to treat intractable epileptic conditions. So patients who had treatment-resistant epilepsy.
Is this, what is it? It's in the 80s? What did
This
you?
is in the mid 90s,
The 90s. Okay.
mid 90s. And this was a radically different approach because it was clear, number one, that they were getting seizure control, that they had, profound anticonvulsant effects. But was also clear was this was a technology where you're wrapping an electrode around the vagus nerve in the neck. And the thought was that 80% of the fibers there are afferent to the brain, and that the major waste station was deep, deep, deep in the medulla, the tractus solitarius, which then modulated the locus coeruleus and the dorsa raphe, these deep brain regions that were fundamental to theories of depression, certainly in terms of their role in catecholamine release, serotonin and norepinephrine, and so on. But it was clearly a bottom-up approach.
So let me talk about that because I do want to put that in the context of what we talked about so far. Up to now, when we talked about ECT and also TMS, electroconvulsive therapy and transcranial magnetic stimulation, first of all, we're talking about non-invasive techniques. So these were non-involving implants. And secondly, they are transcranial, right? That's the transcranial and magnetic stimulation, but also in ECT, where in both cases, the transducers are on the scalp, but we are going transcranial, which means we're trying to deliver current through the cranium into the brain. And therefore, you might think that the primary targets are cortex. But what you're describing now is something very different, where now, first of all, it's an implanted technique. It's stimulating the vagus nerve, which is this major cranial nerve, and it's targeting it as it exits sort of the cranium right here in the neck. And you're stimulating it, and so you're distinguishing between, let's say, top down, cortex down, and vagus nerve stimulation, which might be imagined as a sort of bottom up approach heading in this direction.
Right. And absolutely correct in terms of characterization. Even more so, one of the profound contributions of TMS to our thinking is here is this punctate, rather focal, far more focal than ECT, whose mechanism is through the generation of electrical fields in the brain, through the, in fact, induction of depolarization, but whose reach was only really, a centimeter or so deep into the cortex. And so anything that it was doing that was more widespread was a polysynaptic phenomena, and that was a consequence of the physiological changes induced by the stimulus. But from the point of view of the stimulation technology, it was truly limited to the cortex. And my thinking about ECT always emphasized really its cortical representation largely, because what we were doing when we were churning the dose up of unilateral ECT, making it an effective treatment, was we were shifting the site of seizure initiation from the motor strip to more anterior prefrontal tissue. We were exceeding their thresholds, was my view. And so, even though certainly within the field of ECT, things like bilateral ECT, which was a gold standard, had a deeper impact, its electrical fields would involve a greater degree of the brain. That wasn't necessary to the efficacy of the treatment. It was that the more and more we were, because when we, for instance, reduced pulse width markedly, that was not just a manipulation of the efficiency of the pulse. It was also a manipulation of the depth of the stimulus. People often haven't appreciated that there's a strength duration function, and as you make the stimulus weaker, either in pulse width or in current, you're going to be more focal, and so you change the geographic distribution as well.
I want to ask about that we talked in an earlier part about, is it the electricity that the ECT is putting in directly, or is it the seizure? So now, as you're talking about targeting, are you targeting the electric field, or are you talking about targeting the seizure?
Well, both, because where the seizure is going to start is going to be a function of your electric field, right? And you're changing the pathways when you change the parameters of the stimulus. That's the only point I was making in this context, that it was pretty superficial,
Right.
uh, what we were thinking. And that led to the great emphasis on prefrontal cortex, and in particular in the mechanisms of these
Mhm.
antidepressant treatments. And so here was this intervention that was starting from the bottom up. And what was also very different about it was that the time course of the effect in epilepsy was something we had never seen before. It's not that people get better when you turn on VNS for the first time. It takes often months for you to see a therapeutic effect. And it turns out that that's also true in depression, that we now have, when you think of it, interventions for depression that display profound antidepressant effects as a matter of hours, like ketamine, or to some extent like ECT, or it may take months or years to see the therapeutic effect. And that was true of knowledge of VNS in epilepsy to begin with. And so it seemed like in many ways you were resetting a tone in the brain that was that had a very different path than our standard treatments. And because of my view that the anticonvulsant properties of ECT were fundamental to its efficacy, here was another new anticonvulsant, clearly VNS. And so the question was it of value? And many people, I think, agree that one of the greatest discoveries of the 20th century in psychiatry was the role of anticonvulsants in bipolar disorder in particular. That what we now call mood stabilizers, that the same drugs we use to treat seizures, we often use to reduce the cycling in bipolar disorder, and sometimes are effective or of consequence also in unipolar depression.
I just want to put a point on what you just said because it's a nice point. So you're saying your work with ECT, the seizures produced, this then triggers a anti-seizure adaptive response by the brain, and the
Right,
hypothesis was that that's what was driving the mood improvement. Okay,
right.
now you have another technique, VNS. Now this does not produce a seizure, but it's by design, or it's intended to activate these same anti-seizure processes, and that's where we're saying, well, therefore we have anti-seizure processes. As with ECT, we now have a path towards mood adjustment.
Right. And for what it's worth, in terms of modern development, one of the ways this has played out is we now have GABAergic antidepressant drugs that are used to treat postpartum depression. That idea that we need greater inhibitory transmission to treat the depression has become, I think, more widespread. But that was my thinking back then, and I approached the company early on, saying, "Let's study this in
Then
depression."
Cyberonics, right? Then called
Then
Cyberonics.
they said they weren't interested. And I know Bob Post, who, as we mentioned last time, was Mark George's mentor had the same idea. I mean, he was really one of the great intellectual leaders in introducing anticonvulsants in the treatment of bipolar disorder in particular. And so he was championing the idea that we should maybe consider this. And what happened was the company a couple years later went to Mark and said, "Are you interested in doing a study with us?" And Mark said, "Well, yeah, I'm interested, but why don't you speak to my friend Harold?" And I said, "Why don't we round in John Rush in Dallas?" And John said, "Let's also include Lauren Mangarel." So those were the four sites that did the first work using VNS in mood disorders. And the intention from the start, rightly or wrongly, was for people who essentially had run out of options. That the population that is being considered at the beginning with almost all the brain stimulation, newer brain stimulation technologies, is a resistant
Right.
population. That
Something we talked about in other parts. And like you said, for better or for worse, these are refractory and so very difficult to treat patients with.
Right. And VNS and to DBS in particular in the mood disorders, because they're surgical, is reserved for people who have not done well with many, many things. And VNS in part because it has some annoying side effects like voice change because of the overflow of the stimulation to the vocal cords when it's on, is also one of its limits. But what was we did the first study and found that about 40 to 50% of patients after a year were showing some degree of clinical improvement, some degree of meaningful clinical improvement. So this sort of confirmed that in depression, it's like the time scale is
Mhm.
like in epilepsy. You see further and further improvement up in those initial works up until about 18 months. Nowadays, it may be even because it's more resistant patients 2 years or longer for it to show peak clinical effects. So this is a slowly changing phenomenon.
Can I
In
ask
a
you about that for
sure.
BNS, for DNS in general? I mean, something that takes a year to act or more, that creates a lot of burden as far as designing a clinical trial and also as far as establishing efficacy, right? Because patients are not stable. These trials might become much more expensive. There's a lot going on in these patients' lives unrelated to the trial, right? I mean, does that really raise the bar as far as the challenge of establishing?
Yeah, it's the bar is raised even further. I'm glad you asked that because what is also true in this population is that the likelihood that they're going to ever remit, become asymptomatic, is remote. And that lesser degrees of improvement can make a meaningful difference in their lives, but for the very reasons you're mentioning, the instability of it, the life changes that are going on, all of the other stressors, and so on. How do you establish that meaningful effect? It becomes very, very expensive to do that largely.
But the
And
long duration adds essentially noise, and then the
so, so,
patient
so
selection makes the signal small because they're hard to treat.
and that was reflected sort of to make the package complete. What was exciting about this technology clinically was not the number of people who benefited, because it wasn't overwhelming. It wasn't like ECT where you expect 70% to remit. Here we were saying maybe 40%, 50% after a year might be responders with very few remitters, right? And but what was exciting about it was that if you benefited, you held it. And that was the discovery that prompted the approval by the FDA review committee, essentially the recommendation to the FDA by the scientific and medical community was to approve of this, even though the study that was presented to them, the first study, was a failed study. After our initial pilot study, Cyberonics, we studied 60 patients at these four sites and documented that a number of them got well, and that if they got well, they stayed well, that sort of thing. When Cyberonics then did its pivotal trial, it did a 10-week sham controlled design, right? A period of 10 weeks, and something that takes a year to show clinical benefit, right? With a lot of noise. So that was not a failed study in terms of just missing its endpoint in a design that was too short a period, given the nature of the clinical benefit. But what was also manifest there is, and this was observed just the night before the presentation to the FDA committee, was that the people who did well stayed well. Everybody was followed for at least a year or longer afterwards. And that was unheard of because we're writing about this now with the modern Levanova trial. The,
Levodopa, which is essentially the new name for
the,
cyberonics, yes.
yeah, Levanova, a very large neuromodulation heart disease company, bought cyberonics and bought this technology. Um, and the point is that the more treatment resistant you are, the more trials you have failed, it generally is the case that that predicts your lower likelihood of benefiting from the next treatment, but also if you do benefit, your likelihood of relapsing.
Mm.
So going back to the work in ECT, that was the work that generated a lot of our approaches to measuring things like treatment resistance. How do you go about deciding that somebody is treated and what it constitutes an adequate trial and not, and so on. And there's now really a science of that. And it's an indication that it's a spectrum. And that the people who have the greatest degrees of resistance are the ones who, for instance, in STAR-D, after you failed two antidepressant drugs prospectively, your chance of both benefiting from the third or the fourth,
Yes.
holding it for a year, was less than 5%. So in the current RECOVER trial, the Levanova trial, the sham is 1 year. So people are activated or not for a period of 1 year because of the time course of the treatment. The,
I want to go back to that. I want to get there, but I want to go back to that FDA decision. So if you can just say more about it. One, okay, the benefits are durable, but is that because the device is still on? So on, TMS, you stop your TMS, ECT. So it's good that it's durable, but it's like you're still taking the pill.
yeah,
Could you also talk about what happened specifically with the trial not working, but then FDA ultimately allowing it?
sure. The durability, why it is durable, is something that we can speculate about. The major contentions are being on 24/7 means that you're going to continue to get the benefit and that there isn't poop out in the stimulation pathway, that the stimulation pathway functions in a way that it keeps the effect going. And that's very much like, I think, some of the thinking in DBS for Parkinson's, that if you stop the stimulation, you get immediate loss of benefit. But that, to some extent, can't be true with VNS, to the extent that, one, its onset is very different than the onset with Parkinson's, where in Parkinson's you see the benefit in the operating room and you decide where you're going to stimulate, which pair of electrodes you're going to turn on as a function of your immediate clinical benefit. VNS may take months to years to show its
Hmm.
clinical benefit. And we don't know, and it's certainly not the case that if you turn it off for a day or two that you're going to see the type of relapse that you would expect with Parkinson's. So that there's an intrinsic durability, which is different. Now, very importantly, I've theorized that in depression, the longer it takes you to get well, often, the longer it lasts.
Hmm.
And as a general phenomena, so that the interventions, biologic interventions, other than the psychedelics, which are in a sort of, we could talk about in a class by themselves. But if you do sleep deprivation, about 50% of depressed people will have an antidepressant effect
Oh.
within 1 day. But they can't, because you can't keep people awake all the time, they relapse. Almost everybody relapses. The same with ketamine, that you can get within 2 hours a marked antidepressant effect, but that antidepressant effect will last on average maybe 5 to 7 days. It has
Hmm.
a very short life span. Accelerated TMS. Now, we can within 5 days get a profound through Nolan's work, but it also looks like those are the people that are relapsing very quickly after obtaining that immediate effect. And that, I think, is also part of the issue with ECT, is why you have 50% of people relapsing, and most of it is after when you discontinue the treatment and so on. So in actuality, psychopharm and psychotherapy have better durability often. than these other interventions, and they also take longer. So it's not hard to see why a neuroplastic effect, which you build over time, may have more stability than one which you have a very short life in building. That's something that's we're thinking about, as one of the possible issues. And that, by the way, will be the trade-off in TMS. Is if this type of thinking is true, is because you have better durability with standard TMS, I think, than you do with accelerated. And so you'll have to get a trade-off as to what's the optimal balance there, spreading out the treatment in time versus accelerating its improvement.
Or
So,
add maintenance, or
right.
potentially add
So you can
maintenance.
see how, in any case, VNS is incredibly interesting because of. And then when you think psychedelic, the psychedelics blow this all up because they're showing that single dose exposure can result in 6 months of
Mm.
and there the interpretation is that it's the nature of the reframing of one's perspective on life that is
Mm.
fundamental, and there are all sorts of tests of that going on. So.
So what won the FDA over again? Going back, was it a mixed bag? Was it a split decision kind of thing? Was it?
When the panel that heard the evidence on VNS voted to support it, it was largely swayed by the clinical argument that, for instance, at Columbia, our patients had averaged over 20 drug trials. All had failed the ECT with us. Patients not only showed some benefit late, but they held it. And that seemed to be convincing to them that not just that you could get movement in a snapshot in one point in time, but that it was something that was reasonably durable, which is totally unexpected in this population. Again, to give you an example, in the ongoing recover trial, patients average more than 13 failed treatment trials beforehand, and they're in their 18th year of their current episode. More than half of their life, 50% of their life, has been in a depression. And uh, that's a very, very different type of patient population than, for instance, the patient populations that we think about for TMS and so on. These are at the very other end of the spectrum.
Could you put that in context again? Eventually did pass through the FDA. The fact that there's another trial being run now suggests that there was, at least from the clinical community or from the perspective of the company, a need to
Oh yeah, no,
revisit the
absolutely.
trial.
No, what had happened at the FDA was once this recommendation was sent to them, the FDA scientists reviewed it and rejected it. They said, "No, you guys don't have class one evidence. We don't care how compelling it is that you have this durability. This thing does not deserve to be approved." And so the FDA official response was to turn down the request for approval. It was disapproved. And that then led to a political process, which played out in the halls of Congress and the New York Times, and with Senator Grassley, who's still around, weighing in on this. But essentially, the FDA was, I think, probably pressured is an appropriate term, pressured to rethink that. And there was a meeting where the FDA minister in charge of this had this FDA scientist who had reservations about VNS, and two independent scientists, John Rush and I,
Mm.
who met with at the FDA on exactly this issue, and hammered out a agreement that we reviewed all of the data and we reached some consensus, and the FDA then decided to approve of it,
Mm.
to approve VNS. So it was, and within the academic community, obviously, there were eyebrows raised because of to get the FDA to reconsider it was a political process, not necessarily a scientific one. And as a consequence of that, perhaps VNS was one of the very first treatments where to my mind, there was a dissociation between the action of FDA and the action of the Center for Medicaid and Medicare Services,
Okay.
CMS. CMS had a coverage decision where it determined that it would not cover VNS for depression. This is not an inexpensive intervention where
Right.
you're doing surgery. And clearly, part of their worry, I presented the CMS, I think, on 2 occasions. John Rush and I both did. And part of the worry was that we use figures like 30% of people with major depression are going to be treatment resistant. And treatment, not, there's a big avenue of treatment resistance in terms of the level that we're talking about for VNS or what would be coming to TMS. But their worry was that there would be tens of millions of people who would be considered for VNS because of what the boundaries were, lack of boundaries
Yeah.
and so on. That was one of the issues. So VNS uh, did not receive reimbursement via Medicaid or Medicare, and when the U.S. government services did not provide reimbursement, then private insurers have no incentive to either. And so that resulted in the fact that even though it was approved, very few patients were getting it because it was non-reimbursed.
Okay.
And along the way, Scott Aronson published in 2017 a highly important retrospective paper in the American Journal of Psychiatry that looked at the registry. As part of the original FDA approval, the company was required to have a VNS registry, and it collected essentially a little over 1,000 patients who had VNS and were treated with treatment as usual, and similar patients, highly treatment resistant patients, but who were not implanted with VNS. And that paper reported quite meaningful differences in antidepressant effects and the longevity of those effects between those who had VNS and not VNS. And it prompted CMS to essentially ask, should we reconsider what we did and now reimburse this intervention? And to do that, as part of that reconsideration process, they had a meeting in Baltimore where just a methodological meeting. How do you diagnose treatment resistance? Is it reliable? Is that have predictive value? Is it something as part of their decision making in terms of whether to reimburse it? And this was consequential because I don't know the reality of how much this trial costs, but my guess is it's around $300 million. And with CMS funding a substantial portion of it, the surgeries, the implants, and so on. And this is a study of 1,000 people who, half of whom get implanted, all of them get implanted, half of whom get turned on, the other half don't get turned on for 1 year. And then everybody is followed for 4 more years. So it's a 5-year outcomes in these highly, highly resistant patients, half of whom are unipolar, half of whom are bipolar. And it's the unipolar where we now know the outcomes.
I see. What you just described, the cost, the time, right? It goes back to what I asked before about when you have treatments that again maybe take a long time to wash in, and for other complicated reasons, the costs are massive. And as a result of that, it also seems like you don't get a lot of shots on. You're not going to do 10 of these a year, right? You're going to get one of these a decade.
Right.
Um, I mean, I think there's more to say with the VNS story, but I wonder if now is a good time to bring in another technique that I think emerged between the time of this first VNS trial to the one that's being run now, and that's deep brain stimulation. And I don't want to spend too much time on it, but I more wanted to ask you at a very high level, what does the experience with DBS for mood, which is an ongoing experience, right? The trials, what are the broad lessons from that may apply, well, that are relevant both for DBS, but across neuromodulation for depression?
Well, I would start with, I think, almost as a teaching vehicle, it's easier to start with DBS for Parkinson's and say what the broad lessons are there and what do they teach us for DBS for depression, or what we need to know in DBS for depression. The very first thing about DBS and PD, and it may be true in depression, is it illustrates the fact that putting electrodes in the brain and improving function may have nothing to do with what's wrong with you to begin with. And that nobody would argue that putting electrodes in a healthy piece of tissue of the brain and buzzing it, taking offline, cures Parkinson's disease.
Meaning Parkinson's isn't caused by a lack of metal
Right.
electrodes in the brain, and it's not caused by a lack of extra electricity floating around in the brain.
And even more so, we know that the primary lesion that we're dealing with is upstream to where we're stimulating,
Mm.
that we're not even going in the neighborhood of where the problem arises from. And we know that the problem is a result of the lack of transmission of dopamine in a particular set of synapses. And we're going down 2 subway stops down from that.
Mm.
And we're buzzing that tissue and cleaning up the signal.
Cleaning up the signal. Yeah, okay.
Right, right. So this is a signal that ultimately gets expressed in the motor cortex, and somehow by going in, and one of Benabid's really brilliant maneuvers was showing essentially that doing it at 20 or 30 hertz didn't work. That when you went to 120 hertz, all of a sudden people could move again.
Right.
And uh, and so that there's an engineering, a science to intervening in these chronic illnesses where we modify their expression that may have very little to do with their pathology. And in psychiatric illness, I think it's even much more complex because life changes our circuitry in all sorts of ways. And where things started from and why they came to be may have very little relationship to the what the current wiring diagram is.
Or the paths that we can access to fix those, right?
Right, exactly, and
Right.
so on. And of course, ECT is a brilliant example of that because nobody ever got depressed because they lacked a seizure. And yet that may be a central ingredient in moving them. So that is one of the things, and this is one of the things I think about and think about the future brainstem, because I think we can move to more fundamental interventions where it's no longer just shaping the expression of the illness, but thinking more about the likelihood of these
Mm.
episodic things occurring and modifying essentially the substrate that allows these explosions of malfunction to occur.
So related to that, this new way of thinking, based on this new way of thinking, you might criticize the approach to TMS that views depression as, hypofunction of some part of the brain here. And when we do TMS, we simply turn that knob up to bring that activity up and therefore reverse the sort of the disease etiology. So you would also maybe push back against, as you did in an earlier part of this interview, against adopting too simplistic of an explanation. Again, even for TMS, that all we're doing is reversing the dysfunction.
Right. And I think we have to be really humble. I mean, one of the things I learned in my from the imaging work I did in ECT was it was very clear that depressed people came in with hypofunction of their frontal lobes. That was tons of people at the time, Baxter and others were all demonstrating that. That was some of the most important discoveries in affective neuroscience. So what does ECT do? It shuts it down more. And the more it
Mm.
shuts it down, the more it shuts it down,
Right. It goes
the
up. Right.
better you are. Right? Okay. You explain that. And yes, there are ways of getting it. This is sort of almost becoming Talmudic. But it could be that what we're seeing is the reaction of the brain to being depressed, that it's trying to do what ECT does, but ECT does better.
Yeah.
Right. But there are all sorts of ways. That's sort of like the hypofunction of the left fixing it sort of thing.
Okay.
And at a much larger level, these major psychiatric illnesses, whether they're mood disorders or schizophrenia or bipolar illness of some types, or OCD, panic attacks, are all stress sensitive. They're all phenomena where ongoing difficulties in life can trigger. And so the bigger questions are, why is it that 25% of people, when exposed to trauma, develop PTSD, but 75% do not? Why does loss result in depressive states often that are unending in some, but not in others? So what is it? That is. that sort of thing. And that, I think, is something that brain stimulation will is well equipped to address in the way ultimately of instilling a resilience as a goal of treatment. And I think what I teach, there's wonderful preclinical animal work which shows that we could instantly change an
Hmm.
animal to be socially dominant or not. That is essentially the same area of the brain that we learn where we have control or not. And this is sort of going back to our discussions about what depression is. I was highly influenced by Marty Seligman's demonstration that you can give two animals, dogs initially, the same amount of electric shock or pain, but the animal that could control it would not stop eating, would not give up on escaping, and so on. And the animal that couldn't control it went into this depressive syndrome. And that was a clear demonstration that it wasn't just being punished, but it was the idea, the abstract notion of control that which
Hmm.
which you see expressed even at the rodent level. So it's obviously not propositional, and that is fundamental, I think, to the grit and effort and determination and how long you are in the forced swim test swimming and that is essentially. And the neuroscientists that study helplessness and so on agreed that medial prefrontal dorsal premedial frontal cortex was fundamental there. And so it probably is a case that the same factors that are going to help you compete in life are also going to help develop a resilience against illness. But I think that is one of the ways that we're going to go in the future.
So is it correct to say what we're saying is instead of thinking of brain stimulation as reversing the etiology of the disease itself, essentially treating the disease, the brain has its own mechanisms for fighting these symptoms, right? And the stimulation is boosting those mechanisms, right? So if it's resilience, then brain stimulation is essentially boosting resilience.
Yeah, all we're doing is depositing energy, right? And we're trying to activate some circuits. So those circuits better have the type of therapeutic effects that we hope they do. It may be, for instance, that here detecting whether somebody's hallucinating is a different thing than detecting what they're hallucinating about and the content of their
Yeah.
hallucination. Right. And we've been spending a lot of time as a field trying to figure out the content of each
Hmm.
person's trauma. Right. And in many ways try to undo it through and fundamentally, if these are expressions of amygdala hippocampal circuits, let's say, it doesn't matter necessarily what the content is or how it got there. It's at that level.
The circuits have to be treated.
Right.
All right, this may be a very good time because we're starting to talk about brain stimulation and themes in general, maybe to transition to talk a little bit about
Mm.
the start of the journal, the brain stimulation journal, how that started, and of course now the conference that's associated with it. So I'm sure you were busy enough without having to start a journal. So what was the thinking, the motivation, the goals for the journal, and how has that gone as far as what your vision was?
Well, I think Mark and I and Josh Spieler, the three
Josh,
of
the
us,
publisher, the
the
Elsevier
publisher
publisher of
of
yeah.
Elsevier, would we're blown away by how successful this journal has been and how much impact it's had on our field and its development. It didn't take great insight to know that this was a emerging field of medicine
Mhm.
that with extraordinary potential. And what was really unusual and remains unusual about our field is that it is so interdisciplinary
Mhm.
that there's really very little distinction between neurology and psychiatry in the contributions here. This is one of the areas where it isn't, or neurosurgery. It's not divided up by
And engineering and neuroscience
and
yeah.
yeah, I'm getting all of those
Yes.
that all of us are in this soup and we learn from each other and we make each other better
Yes.
and in a lot of ways. So that was sort of the vision at the beginning, saying there isn't a place and we need to have something that will embrace the neuroscience of stimulation. It's almost like thinking I just saw yesterday um, on the ACMP's website, they have a little video from Joel Elkes, who's one of the fathers of psychopharmacology, and he was talking about what were the first meetings in psychopharmacology.
Hmm.
And it turns out the very, very first meeting of International Meeting Psychopharmacology was held at the place I went to school at Magdalen College at Oxford,
Okay.
where Sherrington had
Yeah.
taught and so on. And a small group back in 1951, and
Huh.
that was sort of a bit like the feeling of some of the early meetings on TMS and early issues with the journal. To tell you the truth, I pitched the idea of this journal, to Josh Spieler in Toronto, I guess around 2006 or something like that. And at the time, print journalism was dying, because the internet was coming around and people were downloading materials. And
Right.
I mean, I used to subscribe to, I don't know, 10, 15 journals that I had shelves and shelves in my office full of, nobody does that anymore. Right? And so the business models were going away. And on top of that, publishers were not starting new journals because they thought they were losing their pants on the ones that they had. And that the only journals they thought were successful financially for them were those that had a society,
Hmm.
right? So, and then, well, like the Society of Biological Psychiatry, which is published by their journal, Biological Psychiatry, published by Elsevier, they own the journal, that society.
Hmm.
And there are differences whether sometimes the journal is owned by the publisher or not. But my feeling at the time was I didn't think that the politics of a society was something that we needed to burden this field with to begin
Hmm.
with. And that particularly because it was so broad in its disciplines that you wanted included and represented. So that how would you get people to sign on to from the beginning, something that,
Yeah.
right? So,
So it was a journal was born without an associated society. It was just a journal.
yeah, and no subscription built in and so on. But at the time, it was the university subscriptions
Right.
were applying for it. But Elsevier went for it. And at the time, I was diagnosed with a pretty serious illness and felt that I couldn't take over as editor in chief. And so I did the really smart thing. I got a guy who did a much better job of it than I would have ever done. Mark George invited Mark if he would be the editor in chief instead. I would stay on as the
As a
founding editor.
postscript, by the way, you got better. But anyways, when you got Mark George to come on as
Do the
editor in chief.
job. And Mark spends 2 to 3 hours a day, almost every day of his life, devoted to the journal, and an extraordinary commitment with a perspective on the field, which is really profound and sensitive. And so he's done and so the journal
And
is
by the way, I see that right now as the
having to
technology
do the
editor.
work and seeing how your child has grown up,
I agree. But I want to talk, I want to emphasize how much more, I mean, again, I see that now as a technology editor for brain stimulation. He
Yeah.
reads every single submission, and then that comes in with an editor-in-chief level of review, then going on to the deputy editors, then going on to editors and reviewers. So the papers going through brain stimulation receive a level of attention, constructive feedback you're not going to get anywhere. You know that when a paper comes out in brain stimulation, the brain stimulation is solid. You know what I mean? That aspect of it has been it's gone just through the highest level of rigor. But go ahead. So yes, the journal exceeded your expectations.
Yeah, and that is because I think the field has exceeded everybody's expectations, the growth of this field. This is a field that is largely technology driven.
Yeah.
It's not that our understanding of the brain has had such a radical improvement in that
Yes.
we now know what to do better. It's that we can do things we could never do before. And in many ways, we are figuring out what things mean afterwards because we're saying, wow, we could do this and this is what happened. So the organization must reflect this or that. So,
And I love that point. I want to underline. You're saying the growth of and the success of brain stimulation. I mean, past 20 years, especially the past decade explosion, has not been driven by necessarily fundamental breakthroughs in what we know about plasticity or depression, which, I'm sure there have been advancements, but probably I think the level of advancement has perhaps been disappointing for many.
Hmm.
What has driven the explosion in brain stimulation is the technologies that have been introduced. We can talk about all those we talked about several of those technologies so far. We have now new emergent technologies, and so it's those technologies, that engineering that was then put in the hands, right, of neuroscientists and clinicians that are driving the excitement and the innovation.
Right. Obviously, Tony Barker gave us his event,
VNS, yes, we talked,
gave
yes,
us
yes,
a tool that got translated into so many different fields and so many different
yes.
applications right away. But it was without the tool, we wouldn't have been anywhere. And we're often limited by the tools that we have. That, for instance, magnetic seizure therapy was a great idea, but it's limited by the electrical engineering that we can't get a strong enough charge, so to speak, in the brain via a magnetic stimulus. It's simply
Until one was made.
well, no, but we could produce a seizure. But I'm saying to this day, the efficacy and the utility of the treatment are limited by its depth and degree of
Yes, I
penetration
understand.
and so on, that we have technological limits that we will ultimately be challenging and exceeding. But yeah, no, that technology is, I think, what has driven us. The fact that we have DBS, that Ben Abid did the demonstration, that high frequency, and the other, one of the very clear things about DBS is that blew me away, is sometimes in brain simulation, we're going to need to be non-focal. The, for instance, VNS is not a focal intervention. It is impacting on nuclei
Moving
that
up everywhere. Yes.
then essentially like sprinklers
Hmm.
sprinkle neurotransmitter across the cortex, change things like signal to noise ratios, um, and and have God knows what the longer term impact is. But in DBS, we have an intervention where if we're a millimeter and a half off, we can not only not get our effect, but produce completely different effects. We're getting mania and depression when turning on the wrong electrodes. So that at some levels there is an exquisite level of precision which is needed, and at other levels precision may be, in fact, our enemy. I know that, for instance, whenever I've reduced the footprint of ECT,
Right.
I've managed to make it not work, and so so these are incredible tools that give us opportunities to change the brain in ways we've never could have changed before, and they are essentially what are going to teach us about the mechanisms of therapeutics. It's inferring them from what happens as opposed to standing there and saying, "I figured it out, and now we need this tool to
Yes.
do this," right?
All right. Let's finish up here by again. I mean, as they say, it's very hard to make predictions, especially about the future, but I want to hear your perspective about where the field is going in the next, whatever it is, the next 10 years. How much of that is tool driven? Do we already have the next generation of tools and now it's time to see how far we can deploy them? One aspect, we don't even know what tools we'll be using in 10 years. But also there seems to be old tools whose utility we haven't really, I mean, right? There's still work on ECT, there's still work on VNS. So yeah, where do we stand and how do tools play a role in this in the next 10 years?
It's one thing to think about what our targets are. Where do we want technology to go? Where do we want to invest in terms of where the largest payoff is going to be? Non-invasive focal pharmacology will be one of the main directions of the future, as will non-invasive energy deposit. And as part of that, we'll get to is what will we be doing to read the brain.
Can you explain, first of all, what you mean by the non-invasive focal pharmacology?
Nowadays, when we take drugs, by far what we do is we administer them systemically. We
Right.
swallow a pill, and typically we have to poison the body in order to get enough of a molecule into the brain to have any behavioral effect. That's because the brain really prevents larger molecules from entering, right? And so we have, in psychiatry, we have the metabolic disturbances, we have the sexual disturbances, we have all sorts of things that, and it's across of all of, when we treat Parkinson's disease, for instance, I got so many patients from San Juan to treat with ECT who had Parkinson's because they were psychotic, and they were psychotic because of the drugs that were given to treat Parkinson's, and because the drugs were going not just everywhere in the body, but everywhere in the brain. And we know if you overload with pro-dopaminergic agents, you produce psychosis, and it's a different system than what you need to treat the movement disorder. And this was illustrated beautifully. I did some work with Dan Abrams, who's the CEO, was the CEO of Cerebral Therapeutics. That company was bought by Biogen, and is now the CEO of Neuro Insights. And Dan was a chair of neurosurgery at Children's Hospital of Denver when he lost his eyesight. He had specialized in removing tumors from the brain of children. And he humbled himself from being the chair. He did a new residency in psychiatry. And while he's a resident, fellow resident says, wouldn't it be cool if we could shoot clozapine straight into the brain? And he said, I could do that. And what he meant by that is he had put ventricular shunts into the essentially the ventricular system of the brain to relieve intracranial pressure thousands of times, and that he could use that pathway under MRI guidance to send medication to specific area of the brain. So that, for instance, the lateral ventricle is the floor of the lateral ventricle is the hippocampus and the amygdala. And he put a pump in the stomach wall, in the abdomen, with a catheter going through it and into these shunts in the brain, and recruited patients. We did this work in Australia. He recruited patients with epilepsy who were treatment resistant and were not surgical candidates because they had medial temporal lobe epilepsy. You didn't want to leave them aphasic. And he had them all fail sodium valproate. And he gave sodium valproate through this shunt at 1/10 the dose that they failed orally. And he got 70% seizure control, 3 out of 5% seizure free. And
so that's focal pharmacology, but that's not brain stimulation.
That's not brain stimulation, and it's focal pharmacology invasive. And you don't
and it's invasive, correct?
Right. I had actually written the protocol for that company to do exactly the same thing in profound treatment-resistant PTSD because of the circuitry that you could easily, and that would be a test of is shutting down hyperactivity in the amygdala and the hippocampus a way to treat that, right? But you can see what the attraction is of why can't we send dopamine right to the substantia nigra where the 80% of cells that are dying are no longer producing it? That would be the most rational way of dealing with this illness. And I believe we're about 5 years away from something in that order of when human trials will begin with focal delivery. I think right now
using brain stimulation.
Using brain stimulation, because you can use the stimulation in two different ways. You can use it mechanically to uncage a molecule that is made inert biologically through, for instance, marrying it to a nanoparticle. You can, in fact, they've now demonstrated in animals that you can make the the engineering of the nanoparticle can be such that it is sensitive to different frequencies of ultrasound so that it will aggregate like a magnet under one frequency, so you get 100 to 1,000 times more concentration in the spot that you want, and then another frequency is used to uncage it in that spot. This sort of thing has become routine enough, for instance, that I consulted on a study of psychedelics in Israel where we had in brain stimulation, our journal, a paper indication that you could provoke the hallucinogenic experience of feeling one with the world, the socianic thing, by stimulating specifically the insula on and on, in the context of epilepsy surgery.
Okay.
And And there are other reasons for think that might be really a hotspot for this experience. So now people are doing work in animals where using non-invasive pharmacological encaging, where you send your psychedelic to this region or other regions and so on. So yes, I think that'll be one way. And the other way is, this is all through ultrasound, is ultrasound has shown that it can open the blood-brain barrier locally, that the lock that is preventing molecules from getting in can be changed on a highly local basis. So that allows for systemic administration, but
Yeah.
only local penetration. And that is being developed, particularly in the cancer area, to allow neurotoxins in to particular places, but you can see it's functional.
But
Uh,
if we are combining non-invasive energy application to either aggregate, activate, permeabilize the blood-brain barrier with a drug, is that brain stimulation? Are those papers going to be published in the pages of the brain stimulation journal?
I think it was with Mark, but when we wrote the scope for the journal back in 2006, focal pharmacology was included as part
I've
of the
seen it,
scope of the journal
yes. You slipped it in.
from the very beginning, because, how much does it matter, except to academics, that what the packet of energy is? I was teasing Mark recently because we don't accept things that use sensory stimuli.
Like light flashes, auditory. Yes.
Flashes is auditory, and we get a lot of that type of
Right.
work that's submitted. And what fundamentally distinguishes flashes of light from sending turning on the retina on and off with the so.
Interesting. All right. So the future focal pharmacology and what else? What are you excited about in addition to that?
Well, I think that because it's so mechanical, the focal pharmacology will move quicker than the focal deposition non-invasively of energy, whether that's through temporal interference phenomena or whether it's through ultrasound phenomena. But I'll just use this one illustration to you in terms of how far our field has gone and give you my conflict of interest. The vagus nerve that we were just talking about, the longest nerve in the body, innervates the heart, the stomach, the spleen. And it was long thought that there were some anti-inflammatory rheumatological
Yes.
effects that you get from it, right?
Yeah.
So now we have VNS was approved just 2 weeks ago for Set Point Medical,
Yes.
where it's cervical VNS again, where we're wrapping an electrode around the vagus in the nerve in the neck, but for only 1 minute a day, they're
Yes.
stimulating 1 minute out of God knows how many. And they claim that after 6 months, 81% of their patients no longer, these are patients with rheumatoid arthritis, no longer needed biologic medications, that they had a profound anti rheumatologic effect, sufficient enough to take people off of their drugs and persistent enough, right? Now, and here's where the conflict of interest comes in. My son is leading a company which has been for a number of years now investigating the same idea, but where they're using non-invasive stimulation with focal ultrasound
Mm,
to stimulate the splenic nerve directly, the branch of the vagus that goes into the spleen, with the same aim in mind. And they're trying to develop an at-home device that you use 10 minutes a day, that you strap on, and it detects whether you're in the right position or not, and so on. And this now becomes a home-based treatment for producing the same input. And you can see that the non-invasive is huge. I mean, we were talking about VNS being used in people who had failed 20 trials and
yes.
most aggressive treatment, and saving the treatment for that end of the illness where many people can benefit from the same thing much earlier on. And it's the invasiveness that limits our reach. So that's why I think that's important.
I think that relates to something you said earlier about brain stimulation being a big tent. We talked about, neurology versus psychiatry or neurosciences or engineering, but also invasive versus non-invasive. One learns from the other, one advances the other, right? Advances in one, it actually encourage advances in the other. It's not, it doesn't at all feel to me like it's a competitive, in that sense, a competitive space.
For one thing, there really is a deep science to stimulation that applies across all of the technologies. that when I'm worried about the chronaxi for neuronal depolarization and designing an ECT pulse, that
Yes.
chronaxi doesn't change. So that I think learning from each other really is a case. And I think we can learn from each other also in terms of large issues. In the therapeutics world, you have to be really good pharmacologists if you're going to be really good brain stimulation
Hmm.
people, because oftentimes the people that you're treating are highly complicated. They need more than one intervention in order to get well.
Yes.
These things are synergistic, they're often not opposed. But you also want to have a deeper understanding as to what your interventions are doing to maximize them and so on. And so some of the things I think about it are, is it naturally the case that drugs induce a alteration of biology that counteracts their potency over time?
Hmm.
So is a homeostasis likely, because we get receptor downregulations and we get all sorts of other changes in sensitivity because of exposure. And in psychiatry, that is reflected in poop out and in relapse and those types of phenomena. We hardly know anything about that in the neuromodulation space in terms of the systems that we're modulating. How does our modulation of them interfere with its function over time, or does it
Right.
sensitize it and so on? And that's a question that's will be as important to TMS as to DBS, and certainly any of the things that are doing, with some frequency, like VNS and so on.
So picking up on that point, the notion of combination therapies, I don't see them a lot in the literature. Usually you want to do a neuromodulation treatment, often in a way that maybe is not that translatable. You want clean patients, you're washing them off of everything. It's probably not something you do in practice. Is brain stimulation and pharmacotherapy somehow potentially complementary? And is that an area that has been, at least in clinical trials, avoided for various reasons?
Um, Yes, basically. If you ask questions like what meds help TMS and what meds hurt TMS, we don't have very strong answers to that. And that's the stuff that you need to know clinically. What drugs should you avoid while you're doing TMS and what drugs you will benefit from it? ECT is an easy illustration. The American Psychiatric Association for decades argued that we should take patients off of antidepressants during ECT because they don't help.
Hmm.
They could only contribute to side effects, cardiac effects, and so on. That was the APA's position. And the British, who did those trials in the 60s where they randomized the people to placebo or drug during ECT, they never took people off, even though those trials found no benefit from the antidepressant.
Hmm.
So their practice never reflected their findings, and the Americans' practice had no findings. But we for NIMH, I chaired a multi-center study. It was published in JAMA Psychiatry, where we were trying to ask two questions. One was, do antidepressants help ECT? And two, should you start the antidepressants ahead of time anyway? Because that'll give you a head start on relapse, because
Hmm.
relapse happens so quickly once you take it away. And you can't add lithium. You can't give lithium during ECT because of toxicity effects.
Hmm.
It could provoke so you could only give, so we did a study where we randomized several hundred patients to placebo, nortriptyline alone, or venlafaxine during ECT, and then after ECT, everybody was treated with venlafaxine and lithium, nortriptyline and lithium, depending on where and the people who originally started on placebo were randomized to the two
Oh,
conditions. And what we found is the drugs helped ECT. You had a
right.
50% increase in remission if you were on an antidepressant.
Hmm.
And so that's again some humility for the simulation community. This is our most powerful antidepressant treatment, and particularly people who are treatment resistant. It's not that we have all of the story or all of the efficacy, that there's room for it to be shared with these modalities. And that complicates things, because if you're doing science now, it's very hard in the United States to do total washouts of people, because now the evidence, and there's now more evidence indicates that you're improving it when you're doing the drugs. And so going almost the other way, in the Recover, the VNS big trial, people are randomized to VNS or sham, but they also get treatment as usual, and there can be large changes in treatment as usual.
Mhm.
So there, the science is to ask, on top of everything we can do when we're trying to do our best pharmacologically, do you still see a signal,
Mhm.
VNS? And so talking about the cost of doing studies, that blows it up in part because of all of the noise introduced
Yeah,
by changing treatment.
interesting. All right, Harold, that want to stop there. That I mean that those comments almost open up another
Yeah.
100 questions, but I think we've done a wonderful job. I really wanted to thank you for spending these hours with me.
My pleasure. Are you kidding? It's fun.
Good. Any final thoughts you wanted to leave with?
We are really, I think, as a group, so fortunate to be at a stage where there's such accelerated knowledge
Mhm.
because of the technologies. I said this before, but around 30 years ago, in 1995, there were 200 publications a year or so on brain stimulation, almost all of them ECT. And now we have 6,000 a year. And the rate is extraordinary. And there's so many more differences. I guess I'd like to end with this, sort of this last thought. 2 years ago in Switzerland, a woman who was totally mute had a chip put in her brain, and they developed a vocabulary 250,000 words for
Mhm.
her, which they were over 80% accurate in translating her thoughts into
The
words.
BCI, yes.
Yeah, and at I think it was 60 words per minute. So this person who was completely closed in now had speech. So if we could use AI to figure out the individual words that somebody wanted to say,
Yeah.
we should be able to figure out whether they're hallucinating. We should be able to figure out whether they're having a panic attack. We should be able go. There's
Or if
a
they're sad,
or
most.
if there's, but more so, particularly for the episodic phenomena, we should be able to predict it, just like we can predict seizures hours ahead of time now,
Right.
and we could stimulate to prevent them from happening. That's where the third area of progress that I see is not just at the level of the stimulation technology, but at the level of how we read,
And closing that loop. Yes.
closing that loop. And what has always been so problematic for psychiatry in particular, in the absence of a biomarker, the determination of the illness that's being treated and its severity and its manifest and so on. So
Yeah.
just think of what that opens up.
Beautiful. Harold, thank you again.